Hello, everyone, and welcome. I'm Ruth Chen, and I'm the Associate Dean of Continuing Professional Development at McMaster University. I'll be your facilitator today for the State of AI in Medicine, the Big Picture. This is session one of a four-part series, and I'm glad you've carved out this hour to spend with us. Whether you're joining as a curious learner, a current super user, or somewhere in between, you're in the right place. This session will be recorded, and the link will be sent to all registrants following the session. Before we dive in, I want to introduce our speakers. Today, you'll hear from Jerry Maniate and Eleftherios, or Terry, Soleas, who will be setting the stage for everything we discuss today and across the four-part series. First, I'd like to share a few quick points on a slide that I'll ask Terry to share from his side, and this will orient us before I hand it over to both Terry and Jerry. So before we get into the content of today's session, let me provide a quick orientation on how today is structured so you can get the most out of this session. So we can go to the next slide. Yes, thank you. First, Q&A. You'll have access to that question and answer box at the bottom of your Zoom screen. It will be anonymous and moderated, so you can feel free to submit questions at any point during the presentations. You will not be identified, so please feel free to ask what's on your mind. Second, there's also a chat box open, and that chat can be found at the bottom of your Zoom screen. Use it to share what you're observing or applying in your own practice setting. Some of the richest parts of these sessions come from what's happening on the ground, and your peers want to hear about it. Third, skepticism is as welcome here as curiosity. We've designed this space intentionally for both. You don't need to arrive with a position. You don't need to have a clear sense of where you're going. Feel free to express your comments as they come to you. Fourth, we have 25 minutes at the end reserved for facilitated discussion. That time is for your questions, your reactions, and also to further our conversation based on what Jerry and Terry have shared. And lastly, there are no wrong questions. There's no judgment regarding the questions you raise or the comments you send forward. Okay, let's move on to the next slide. This series has received in-kind support from Ontario Continuing Professional Development Offices and foundational funding from Future Skills Canada. Connected to that, the next slide describes how this program is designed to keep the content balanced and clinician-led. All programs in this series begins with a needs assessment. We start from what healthcare professionals actually want to understand, not from what any particular sponsor wants communicated. The planning committee is comprised of members of the health professions education community. There are no industry personnel on these committees guiding the content that will be discussed in these seminars. Our presentations are required to disclose any and all relationships with industry, and you'll hear these disclosures shortly. Finally, we want your feedback. If at any point you feel that biased information is being presented, please name it. You can use the Q&A, the chat, or feel free to reach out to any of us afterwards. All right, with that, I'm going to hand it over to our speakers. We have a lot to cover today, so I'll turn it over to you, Terry.
Thanks, Ruth. So folks, my disclosure is I'm a paid employee of Queen's University, which makes me highly likely to say nice things about Queen's. I am Queen's special advisor to the provost on generative AI. In the past, I have received independent medical education grants from Pfizer and AbbVie in the spaces of multiple myeloma, hemophilia, gene therapy, and aplastic anemia. I'm the chair of the Royal College's CPD Accreditation Committee and a university representative on the National Accreditation Conference's Scientific Planning Committee. I'm co-chair of the AFMC's CPD Committee, and I'm the founding co-chair of the AFMC's CPD Dean's Working Group on AI. Counterbalancing all of that in terms of giving you an insight into how fallible I can be on some things. I'm still a Leafs fan. I have been my entire life. I will, however, say that we make no endorsements of any AI tools, and we urge you to follow the policies of your organizations and exercise caution to review the outputs of any AI tool. I'll pass it over to Jerry for his disclosures.
Thanks very much, Terry, and welcome to everyone. So my disclosures, I do receive a stipend from the University of Ottawa Department of Medicine for my role as Vice Chair of Member Support, which includes overseeing CPD at our department. I also receive a stipend from the Equity and Health Systems Lab that I started about 5 years ago. I have received some independent medical education grants from CIHR, SSHRC, Royal College, and University of Ottawa. I'm also a member of the Royal College CPD Accreditation Committee and also on the board of directors for the Society for Academic Continuing Medical Education. And to counter Terry's Leafs fan, I'm a lifelong Jets fan and also a Blue Bombers fan for those that are interested in the CFL. I also make no endorsements of any AI tools and urge you to follow your local policies as well.
Thanks, Jerry.
Terry?
So, folks, for everyone's interest, this is the first session in a four-part series. So I hope folks have had a chance to register for the sessions that they are interested in. So session one is the state of AI in medicine, the big picture. And we're talking the very big picture. So big literature review, early insights, what the patterns happen to look like. Jerry and I did a good amount of reading to get ready for this one, reading the standard academic and scholarly literature, some of the literature that happens to be in the gray zone, as well as a decent amount of the AI hype, just so that we knew exactly what people were saying, so we could give some of that vocabulary and perspectives. Session two is going to be on diagnostic AI in clinical care, and Dr. Joel Mokhtar will join us on June 9th. June 15th, Dr. Mohammed Madani of the University Health Network and U of T will join us for AI in care and therapeutics. And then on June 25th, Chandi Chandrasena will join us for delivering the talk on administrative AI, Scribes, scheduling, and referral. We're looking forward to having Dr. Chandrasena with us on June 25th. All the webinars happen from 12 to 1 p.m. Eastern Standard Time. Without any further ado, why don't we hop in with the learning objectives that we have for the big picture in the landscape of AI. So for folks to know, at the end of this session, you'll be able to identify a working picture of where AI is currently developed in clinical medicine and where the evidence is solid versus still developing. We'll be able to discuss a practical framework for thinking about governance, privacy, and consent in your own setting. And you'll be able to identify concrete questions that you can use to evaluate AI use where you work and protect your patients in the process. So in medicine right now, you can, if you were to want to pretty rudimentarily split AI's influence, you can look at it in the spaces of documentation, diagnoses, treatment planning, and operations. In documentation, maybe you might be thinking about ambient scribes, note generation, that kind of administrivia. You might be thinking in the diagnosis space, for example, the um, imaging analysis, screening, decision support, those kinds of heuristics and algorithms that could be AI powered. In treatment planning, you might be thinking in the spaces of oncology, drug selection, drug sequencing, care pathways, the things that influence the ability for the actual provision of care. In the operation space, you might be thinking about triage, patient flow, scheduling, bed planning, that kind of thing. Each of these different domains have different evidence. There's different risks and there's different questions you should be asking, and I encourage you to ask them. So in terms of the most rapidly adopted AI tool, it's Ambient Scribes. So what it does. So for those that don't know, Ambient Scribes listen to the clinician-patient encounter. It creates a transcription, and it generates a structured clinical note for physicians to review and sign off on. So what we know, and some of the evidence that we have from the AMA, as well as some collaborative papers with OpenAI from earlier this year, that physician AI use rose from approximately 48% to approximately 72% in those that were surveyed. It tends to be, and this is data aggregated from across multiple academic centers in the United States and in Canada, about 14 to 30 minutes saved per clinician per day is the average. There's also been some evidence for burnout reduction confirmed through some randomized controlled trials at UCLA in partnership with the New England Journal of Medicine, as well as UW Health from last year. These studies show a particular pattern. For the most part, it's primary care and female clinicians that show the disproportionate benefit from AI scribes. Now, the first true RCT that was published in this space showed that the time in note was improved, but I note that it didn't capture the editing time that somebody would have to spend in order to be using an ambient scribe. So the honest picture is that there are real gains, but there's real heterogeneity. Not every clinician in every setting benefits equally. So you have to be mindful and make the choice that's right for you. So in terms of diagnostic support, there are more than 1,000 FDA authorized devices. So what do we know about this? About 76% of the FDA authorized devices operate in spaces around radiology and imaging. One of these, for example, Viz.ai, is a stroke detector. It has about 1,600 hospital deployments, and it typically saves somewhere around 1 hour per patient. Another one, for example, diabetic retinopathy screening increases exam completion in underserved and pediatric populations. And there are some systematic review evidence that position these best as a decision support with human oversight. Now, some cautions. The real world performance is typically about 15 to 30% below benchmark accuracy due to population shift. Now, I had half a mind to put population shift in danger quotes here because population shift is a really polite way of saying in the real world as compared to in test conditions. So take these tools from testing, put them in the real world, and they typically operate somewhere between 15 to 30% below their benchmark accuracy. I'll also point out that some of these tools have a higher false negative rate. So one of these was a pneumonia detection tool that had a 23% higher false negative rate in underrepresented rural populations. I will also point out that the training data diversity does improve the performance of models, but it does not close performance gaps by race and skin tone. So the question to ask about any diagnostic tool is what population was it trained on? And how does that compare to the population you work with? There are some meaningful gains and some meaningful questions. First, in treatment planning, in Weill Cornell, AI integration of tumor imaging and gene expression data outperformed single data applications, specifically in the context of bladder cancer chemotherapy. There's also been some breakthroughs in terms of an AI-designed drug called retinosertib from discovery to human trials in about 30 months, which seems like a pretty darn faster clip than we've seen with many other drug developments. The NCI is integrating AI biomarker tools across clinical trials, and you can see that sometimes people are partnering with AI powers like Google for creating guideline assistance. That's from May of last year. So closer to home, Mount Sinai has about 1 million plus emergency department visits across the 6 hospitals, and AI outperformed nurse triage estimates for hospital admissions. You can also see that there are some emergency surgery delays that you can have a look at. So in terms of the different costs, what these delays happen to cost, you can see that there is certainly a cost for not being able to act as quickly as we can. A French trial, Shock Matrix, across 8 French hospitals and about 1,300 trauma patients, there were about 20 critical cases, whereas clinicians, or 20 critical cases that were missed by the AI, whereas clinicians missed 21. I will point out that these were not the same patients. This is another argument that I would view as a degree of empirical, that AI is a cross-check, not a replacement, since AI and clinicians tend to make different kinds of mistakes. If we were making the same mistakes, that would be dangerous and bad. Thankfully, we fail differently. So what actually works? So highlighting what we had described before, there is that stroke triage trial. There is an ambient retinopathy screening that there's also that ambient documentation tends to work fairly well as a reduction in burnout. There was a sepsis detection paired with clinician suspicion that we're going to talk to a little bit more. And you can also see that it can play a role in emergency department triage support. Once again, complementary, not substitution. So there are some emerging promising non-definitive spaces that we're going to learn more about in this series and some of the later sessions. So oncology treatment planning, some operation flow management, and some rare disease genomics. So the canonical case study in overpromises in AI. So we're going to talk about the epic sepsis model. Now, epic sepsis model sounds like sepsis, which is in fact epic. No, it is a tool within the EHR epic that was indeed designed to help detect sepsis. So the pitch was between 76% and 83% claimed accuracy. Here's what independent validation has actually found so far. So about 67% of sepsis cases were actually missed. Now, I can't think of very many places or systems that can work with being wrong 2/3 of the time. I do have some experience in this, however. I'm a Leafs fan. Remember, I'm used to things going wrong about 2/3 of the time. That doesn't really work in medicine. I'll also point out that there was a really high false positive rate in this particular implementation originally. About 88% of those flagged did not have sepsis. From some discipline-specific models, you can see that the model itself is skewed to respond to blood culture. So in this case, the model was reacting to clinical workup, not predicting ahead of it. A reactive model doesn't really add all that much to a clinician who's already reacting. I'll also say that the hospitals themselves did receive stipends to actually take up this system. So the lesson that I would take away from this epic sepsis model is that clinicians who trusted it blindly risked patient harm. The clinicians who dismissed it entirely missed potential benefits. Neither extreme served patients particularly well. I think this is a little bit of an allegory in what happens when procurement moves faster than evaluation of that particular tool. So, the hidden labor problem that we can kind of take a closer look at. So this is from Black Book Market Research in December of 2025. About 62% of frontline AI users spent at least 30 minutes per day reviewing, correcting, or redoing outputs. That's very, very rarely considered by leaders in their supervision time in the return on investment calculations. About 30% spend at least 1 hour per day on AI supervision. So the question to ask your institution, when leadership is reporting time saved from the use of AI, does that number include the time spent checking what AI got wrong? So there's a mindset shift that I think we should take a look at. So what this particular talk and what I think an effective AI mindset is, I think it is not blind enthusiasm for AI or straight acceptance of trust in AI outputs, nor is it surrendering clinical judgment. I think it is recognizing that current tools can offer some real benefits, but that blanket refusal is no longer clinically neutral. I think that also declines and is abstaining from potential upsides from these tools. I think we do need to invest in committing to engage critically, transparently, and on the record. Instead of having these uses on the side, I think we need to have these transparently in public settings. So I'm going to quote from Dr. Margaret Lazavotsky, who's the Chief Medical Information Officer of the AMA. We are in a place in healthcare today where physicians are feeling the burdens and the burnout challenges, and they're hungry for solutions. These tools are offering solutions in a way that others have not before. I note she says offering solutions, not that we have to blindly accept them. I think we need to be thoughtful. So, when governance can't keep up, and as the advisor to the provost at Queen's, let me tell you, governance cannot keep up. Just about anywhere. You can try and get ahead, you can try and work efficiently, but ultimately, I think we are kind of chasing the ball on this one. So in the US, there were around 250 AI-related healthcare bills introduced in 2025. There is quite a number of them introduced here in Canada as well. There are two states that don't have healthcare AI legislation introduced by early 2026. In this case, Wyoming and North Dakota. About 82% of AI implementations are obstructed by HIPAA, which was written before AI existed. What this means is the laws as we have them are often stifling and inhibiting the ability to implement AI, even the ones that have been well thought out by the healthcare systems that wish to do that. In this case, in Canada, Canada's Bill C-27, which was an AI and a Data Act, actually died when Parliament was prorogued early last year. So asking AI governance questions is not obstructionism. In my view, it's a professional responsibility. We should be asking more of the folks that are governing AI in our healthcare systems. So this role modeling gap that I was alluding to before, I actually want to position it as being a patient safety issue. So faculty barriers to AI tend to center on personal AI competency, the literacy of our staff, not necessarily student readiness. So when senior clinicians visibly avoid AI, trainees learn from peers, vendors, public chatbots, and social media. And to me, those are not the places that I would like our students and our learners and our trainees to be learning about AI. I'd like them to see AI use modeled in a way that is appropriate by the people that they respect most, the faculty and the attendings that they are working with, their senior mentors. So a common worry from, and this is from Frontiers in Education, an article in 2025, a common worry is that technological progress may outpace curriculum development, which leaves faculty unable to model competent, transparent AI use. I think we've seen the consequences before of what happens when our students know how to do things that faculty don't. And this creates spaces where people are operating without guidance and maybe without the ability to be regulated. So there are two failure modes that I want to draw our attention to. The first is avoidance modeling. So when faculty are modeling avoiding the use of AI, what we do is we render AI use as being shameful and we drive it underground. We don't stamp it out. We don't eliminate it. We just don't see them doing it anymore. And if we don't see our learners doing it anymore or our peers using AI, and they don't do it in front of us because of shame or anything like that, we lose the ability to mitigate its effects because we don't know that they did it. The other is covert modeling when people are using AI without being transparent, which in my view is actually the more harmful lesson. The alternative, a belief that I have, is that sunlight has always been the best detergent. We should use AI visibly. We should name what we are doing and name what you do not yet know about it. If you model vulnerability, number one, people will say, well, this is a good chance for us to learn something about this. And I'm looking forward to that particular section with Jerry. I've always placed an awful lot of trust in Jerry's ability to make us see what we can discuss and to share our beliefs in a way that helps us all move forward. Maybe, just maybe, I trust Jerry. So the shadow AI, the underground problem. So in this case, shadow AI, number one, shadow AI here sounds like something that would be quite a bit more nefarious than it happens to be. In this case, I'm going to explain what it is. Shadow AI is the use of AI tools when they can't be seen or using AI tools that are public when you should be using an enterprise one. So think of it as using AI in a way that the governance in your institution or organization doesn't expect you to use AI. So this is from Black Book Market Research, that same survey in 2025. 58% of the respondents in this market research used generic AI tools for healthcare work in the prior 30 days. These generic AI tools were not enterprise implementations. This means they were using models that indeed were using the data that they were given for training. 17% of them acknowledged including identifiable patient information in public tools. 27% more said that this might occasionally slip. So we're already up to about 44% that have said that they've accidentally or intentionally used potentially identifiable information in public tools. Countering this, only 24% of health systems have a clear enforced policy on consumer AI tools. So there is 76% of healthcare systems that are leaving the ambiguity up to the discretion of the healthcare providers. This is an alarming number to me, mostly as an AI governance guy. So why do clinicians actually use these unauthorized tools? About 45% of them report that it has a faster workflow. So I prefer using this tool, or this tool will get me the answer faster than the enterprise version that I've been provided. Another 24% report better functionality than the approved institutional tool. This is a pain that I think I understand. Maybe, just maybe, the enterprise tools that have been provided to some of us aren't the greatest tools that we would like to be using, and we'd much rather continue using what we have before. There's good reasons not to, in that the enterprise tools afford us protection that a public tool might not. Another 26% of providers straight up say, I was curious, so I used these other tools. So the Chief Information Security Officer of the University of Vermont's health system said that discovering shadow AI in our health system was jarring. Blocking it wasn't a sustainable solution, so we had to find a way to enable safe exploration while protecting sensitive data. There's a couple of different ways that people are doing this. Some of the best ones that people are using are that they use their enterprise provided tools are freely available and don't cost anybody anything to use, and they run workshops on it. I'd like to point out that these workshops are also a great space to be teaching people about ethics, privacy, and patient rights. So we'll get a chance to talk about those a little more fulsomely. So the three questions that I think every clinician should be able to answer, full stop. First, what am I telling patients about AI in their care? And does that meet the standard for informed consent? Informed consent here, we're gonna problematize that a little. Second, where is patient data going when I use this tool? If you don't know that answer, I do not recommend using that AI tool. Third, what rights do my patients have and how do I protect them? These rights, of course, I'm referring to are in and around AI, and I draw attention to some of the work from the University Health Network for us to explore a patient charter of rights. Telling patients that you're using AI is not the same thing as informed consent. So, a JAMA Network Open article in July of 2025 highlighted that 81.6% of patients were comfortable when they were told that AI was being used. After about a minute of explaining how AI was going to be used, when fuller details on data storage, corporate involvement, and AI features, that number fell 25% to 55.3%. So I have bad news for folks. If the explanation you are giving people makes you trust less, I don't think the system you're explaining is all that great. Maybe we have to think through how data is being stored. Normally, giving people information increases their trust in something. Maybe our answer is unsatisfactory if it is on average reducing people's trust in AI. So in this case, I think the lesson I take away is that omitting details to maintain comfort scores is not informed consent. What does real consent look like? So to me, I think the ingredients are what I've listed down at the bottom. So number one, we have encounter-specific verbal consent. Your doctor tells you this AI tool is going to be used. I am using this scribe for this reason, for this purpose. I think that's complemented well by a pre-visit written notice that gets sent out to patients. We should have, in the case of telehealth, a visible or audible recording indicator. We should have options for people to explicitly opt out. I think we do need to tell people in that pre-written notice how data is being stored, what third-party access looks like, what's our retention policy, and then also to tell people, when is your audio deleted? How is it deleted? And by whom? So I'll draw some attention to a charter of accountable use of AI in healthcare, which is co-designed with patients and caregivers. Now, this is from our friends at the University Health Network. I think there's a couple of the folks that are leading this one, but the gentleman that I asked for this slide and to get some help from him is Dr. David Wilger, the Associate Dean of Continuing Professional Development at UHN and a good friend of mine. So David's project, in this case, the collaboration that he's leading for this Charter of Patient Rights, and you can get access to it from University Health Network. If you type in Patient Charter of Rights for AI, you can see that that this particular charter is from an emerging set of literature and guidelines that exists both inside and outside of this guideline. The consensus from these guidelines is that it favors transparency prior to use as much as possible. So informed consent prior to the fact. So this particular Charter of Patient Rights that people should take a look at was built in collaboration with the AI and Healthcare Patient Charter Advisory Committee, and it was funded by Future Skills Canada. If folks are interested, I would be delighted to send along a copy for folks to be able to take a closer look at. Or I suppose you could always email David and ask him. He prefers if people email him to ask him for these things. I was going to make a joke about asking it, about saying that you should email him between 3 and 5 a.m., but please don't do that. So I'll stop here for a second and we'll open the forum up for folks to be able to ask some questions that they've got. And I'll turn it back over to Ruth.
Thank you very much, Terry. This was such a rich and substantive presentation, and I know there's a lot to process. I've received many questions here in the Q&A, and so I will start with, before we get to the question that's on the slide here, I'll start with some of the questions that were raised during Terry's presentation. We have approximately 25 minutes for facilitated discussion, so this time belongs to you. Now, when Terry, you started early on in your presentation, you were talking about the disproportionate benefit for female clinicians. Would you have any pointing to the evidence for where this benefit was found or where you had seen this benefit?
Sure. So in this case, the benefit that I noted in the way that it was articulated, the data itself didn't immediately reveal what the major source for this was. They did offer some theorizing, so I'm going to draw off of that theorizing. I think it's because typically in this case, and this is based on some assumptions that the authors and myself are making, the notes that were taken in this case with scribing definitely went quite a bit deeper. Therefore, since the conversation was longer, the scribe was able to save quite a bit more time in terms of the depth of investigation, the depth of discussions, and a approach primarily that it was more conversational. That hints to me for the primary care, since primary care specialists in this case spend a little bit more time per patient on a given patient on a regular basis, they build more of a rapport with that person over time. I suspect the scribe tool was able to capture more of that and render it in a way that was useful in notes rather than a more quick hit hopping from appointment to appointment perspective you might see in other kinds of care.
Thank you. So I have two related or somewhat related questions, and that is, how are clinicians mitigating AI hallucinations? Maybe I'll start with that one.
Jerry, you want me to take this one?
Yeah, you can start and then I can jump in as well.
Sure. AI models over time have become quite a bit more disciplined in terms of avoiding making those kinds of hallucination mistakes, although they definitely still happen. In this case, one of the ways that they have become a little more disciplined is that they've toned down the creativity that a given AI model is able to take, and it kind of gives the whole just the facts type statement saying that if the data is not provided to me or I don't have access to the data, I won't respond to this, is kind of a little bit more the shift in programming that's being done. Now, in terms of avoiding hallucinations with that on the user end, I suppose it's asking an AI for data that it actually has as opposed to asking it to search for data that it might not have. So in this case, I would be leaning towards using a tool. One of the big examples that folks like to use is open evidence. Open evidence only has a set database from which it draws data. If you ask it a question that it does not have evidence on, it will say, I don't have evidence to respond to this. In the case of when you're asking it something that is in its database, so for the data nerds out there like me, asking it to interpolate, which is asking it to work within its data set to provide an answer that it actually has, it's able to give a matter-of-fact answer on the information that it has, which has been validated. Compare that to asking a model to think outside of the data that it has using the data that it does have. That's called extrapolation, and that's where hallucinations typically occur. So in this case, asking a tool for an answer that it definitely has is different than asking it to, what do you think an answer to this could be from data that
Mhm.
it doesn't have? That's probably the most effective way to combat the potential for hallucinations.
Yeah,
Right,
and just
thank
to add
you.
on to that, like when we look at the two different types of tools that even Terry you referenced, one was a scribe, and the scribe is simply trying to summarize and encapsulate what's already being communicated in that in that conversation, in that dialogue, versus
Yes.
what some of the other tools that Terry you referenced, like the Epic Sepsis tool and all these other things. That's where inferences come in. Right. And
Mhm.
so you're right, like disconnecting that capability will be part of addressing the hallucinations that may exist. Less likely to occur in a conversation, which here's the data set, please summarize. It's
Mhm.
a more compacted, clearly defined sandbox, as it were.
Thank you, Jerry. And this leads to the related question about data input. A participant was asking, how can AI avoid mispronunciations when recording the patient healthcare provider encounter in the Canadian multicultural society, where many may have different accents and different ways of verbalizing their concerns?
I've got a funny story that I want to share first. I remember what if you look at the monstrosity of a first name that I've got, you can probably imagine that I have been on the receiving end of some rather hilarious mistranscriptions of my name in the record. So I'm not naming names. Zoom, that would routinely turn my name into legitimately other people's names or serious medical conditions. So I'll point out that Eleftherios Solea, I believe, and this is for Allison, our program and events coordinator. I'll share this story. It would turn my name, Eleftherios Solea, into Alistair Australia. And it would do it with a remarkable amount of affinity. It would do it all the time. My first name has also been turned into a serious medical condition that I understand is elephantitis, which I understand is very serious and that requires medical intervention. Um, these mispronunciations are definitely to do with the quality of AI that happens to be used.
Mhm.
Certain AI tools are more effective than others, and I will note the trend over time as they have had more training data and have been exposed to training data that is, shall we say, more reflective of the cosmopolitan Canadian society as opposed to being trained on historically Western names. These models have gotten better over time. Are they perfect? No. But are they certainly better and getting better by the minute? Absolutely the case. This question is well founded in that this is an example of the kind of systemic inequity that an AI can perpetrate.
And we need to strongly consider where are these tools developed, and many are coming from health systems or organizations, institutions, or countries in which very specific demographics are captured by those health systems. As a result, that's what is the basis of the training set. Whereas here in Canada, I've had the opportunity to have some great colleagues comment on the fact that because of the richness of the population data that we have in our data sets. So, for example, I work at the Ottawa Hospital. We capture through our Epic instance the data for almost all of Eastern Ontario, which is a massive set, which has very diverse populations, demographics, socioeconomics, all those factors that may be constrained in other jurisdictions or other specific health systems. I'm thinking especially from the United States. where those systems have much more of a private paying kind of system. So in our space, we have a richness that we can harness. The challenge is, and Terry, maybe you can comment on this, the challenge has been the relative poverty of options that we have that are Canadian based and or Canadian developed has led to our reliance on options that are not actually harnessing our strength, which is in this case a natural resource, quote, data. We have rich data, but we don't have the production capability of using it yet. And I think that's a hopeful move in the next little while, that we see this as a sovereignty issue, a data sovereignty issue, especially in light of the geopolitical situation that we find our world in right now. There's an opportunity for Canadians and Canadian healthcare institutions to collaborate and bring this to actually a reality.
Thank you, Jerry. And you're both raising some points that the participants are also asking around consent and informed consent. So before I get to those questions, because there are quite a few of those, I'm going to ask a question about epic sepsis. So Terry, when you were talking about epic sepsis as the example, we have two questions that are connected. So I'm going to put those together. How would you suggest clinicians balance their use of AI to make decisions on their use of AI, or making decisions on their use of AI to best balance the risk and benefit? And then a second question was asking, are you able to comment on how AI performance in sepsis detection compares to human physician performance? This person is wondering if the advantage comes from getting doctors to take a second look rather than getting it right or wrong.
So if it's all right with you, Ruth, I might take those questions in the opposite order. So for this one, the first one that I see is that I think the right approach here, or the approach that I think adds the most value to the independent user and the end user, in this case being the patient, would be for physicians to consider an AI tool as being part of the information that they are using to make decisions. If you use it as part of making the decision rather than acquiesce to it, I think you're adding something to yourself. I term this augmentation. You are augmenting your ability to make a decision based on data that you are being provided. That data is for the moment, I would say, until you actually take a closer look at it, that data is both good and bad. Schrodinger's data, as it were. When you take a closer look at that data, I think it can help you make a more informed decision by maybe catching something that you have missed. I don't think that, and I think the premise behind the question is good. I think that if you use it as a tool to help you make a better decision, I think you're in very good kit. I would also comment that this was the first go around of that sepsis model. There have been others since, and each one has been improving since then. I will point out that the going trend that people seem to be saying an awful lot is that the current model you're using is about as bad as it will ever get, and all future models will be better. That tends to be the case with iterative improvement and the tinkering and the expansion of training data, so on and so forth. These tools do tend to get better over time. We might remember what it looked like, what the early AI generated images looked like, and what they look like now. Certainly, they've gotten better over time, and that seems to be the pattern in clinical tools as well.
But Terry, like when we think about it that way, is there a risk that we could be sort of slipping into, yeah, it is getting better. Yeah, it is getting. What point do we let down our guard and that skepticism, or viewing it as a partner, or as you said, we should actually cross-check what the AI is telling us, not replacing us. At what point do we slip into the path of, okay, now it's good enough? And maybe this is actually an important piece for us to sort of wrestle with, like from the ethics kind of perspective. Responsible AI use should really complement, not replace, human judgment, and in this case, clinical judgment. The clinician, as they are making decisions, is going to draw in different data points, of which now this AI tool is an additional data point, in the same way that we're getting information from the speech language pathologist or the pharmacist or the nurse. There still has to be a synthesis factor here. And if we're saying that AI is going to take it all, is AI going to take the blame if there's an error made or occurs in that kind of situation? So we have to push ourselves in these kind of conversations.
I'm smiling, Jerry, because
You
with a
are.
smile, you've asked me about 17 different questions and thankfully answered about 12 of them, I think.
Yes,
I think.
great. So I am sensitive to time and recognizing that Jerry also has a few discussion questions to pose. I want to consolidate some of the questions that are being raised around consent. So someone has posted this as one comment, and then I'll cluster in some of the other questions as well. One post attendee was saying that there's this practice of posting a paper on AI Scribe on a wall, buried with other papers, and that is being used as the consent or the informed consent practice in their setting. So here are some of the questions clustered together. Is asking for consent to use an AI tool different from using consent for using an EMR like Epic? Can withdrawing consent for the use of AI tools put patients at risk after they are integrated? And what does consent look like when shouldn't we also make clear where data is stored or processed and whether the vendor may be using it to train further AI developments, features, or tools?
So
So
great question.
a
Great
variety of
questions.
questions.
I'll take the third one first because my answer to that one can be fairly succinct. Yes to all. I would very much I would very much recommend that informed consent in this case include where the data is being stored, for what purpose is it being used, when is that data going to be deleted, exactly the concerns that were aired in the question. I would say that opting out from the inclusion of an AI tool is not always possible. And sometimes that is part of the informed consent to say that our clinic runs on using this particular digital health tool. In this case, opting out from an electronic health record isn't always possible. In fact, it rarely actually is to be able to do so. Part of the informed consent is telling somebody this up front before the tool is used. Telling them this before they arrive to your clinic on that day is part of the informed consent process, making sure they understand that we're using this technology. Here's why we're using this technology. If you're going to participate, or if our clinic is going to participate in your care, it's going to involve us using this particular tool. I think in this case, being transparent is the ingredient that turns passive consent, like having a message on a bulletin board, to one that is more informed because you're offering that information to patients. I think that's also a key part of the patient bill of rights that advanced by our friends at UHN.
And I have to agree with you, Terry. Like, if it doesn't include that element, it is purely unidirectional, and that runs a risk of adding to the mistrust and distrust that already exists in the system, which then makes all these other conversations much harder.
Thank you. I have a patient partner question. If a clinician is using an AI tool to generate a report on the patient's condition, does the patient have access, or can the patient have access to the report to validate the information?
I think that that's a mechanics question that varies from clinic to clinic. I personally think that if it's about a patient and they're identifiable and it's generating a report on it, I think that's part of a patient's right to see their health data. I think that's something that can be provided to them. I went and I got blood work last week, and I actually saw my blood work and I saw the report before my family doc saw it. That's involving me in my care. That helps me make decisions. That helps me be contextually ready for that conversation from my family physician. When I had that conversation with him, I was ready because I had this information. That's informed consent. That's part of me being informed and including me within my own circle of care.
And increasingly, you're seeing patients turning to chatbots and other devices or other tools because they can't get in to see their family physician, or they may not have a family physician that regularly sees them. And so in that void, the technology has been playing a very important part in the healthcare experience for many. And so it's important to acknowledge that, but also to say, okay, what are the constraints and how do we educate the public on the use of these tools? Because there are those free tools who, in that case, the person that is using it is actually the product, right? They're using the data for other purposes. And so how do we help educate patients and our communities on the use of technology and when to upload your personal health information? Because that's what a lot of people are doing, often in desperation, because they're looking for answers in an uncertain space.
I want to draw attention that this is another manifestation of a challenge that healthcare has been facing. I suppose we can call it the Dr. Google problem, but we could make it a bunch of other things. I think in this case, what it is that people are able to say, well, these are the results of my blood work. This is what it reveals. What could this be?
Yeah.
Which I think is a dangerous thing to ask, mostly because it could be a lot of things. It doesn't have all the data. It does not have a clinician's knowledge of their patient or their context, or the ability to filter horses from zebras. So in this case, let's assume for a second that my iron was a little low from the blood work that I got. I asked what it could be. It could be a bunch of different things. It could be aplastic anemia. That isn't necessarily the most likely outcome. So I'm like, oh no, I've got this horrific disease. And I immediately start wanting to book an appointment with my family doc to go and discuss how I'm going to persevere over this aplastic anemia that I have. It
Yes.
wasn't that. It wouldn't have been that. Can you see how different kinds of use of AI can cause more problems than they actually solve? In this case, if I had just gone and said, if I had asked, what are these different measures? What are the different things that they mean? What is an eosinophil? What is this? What is ferritin? Why is hemoglobin high and ferritin low? Can someone tell me the difference between these or what these actually mean? That's a way different use than diagnose me based on this blood work that I've given you.
Yes.
But that
And
that also underscores the limitations of how people used their technology in this current day and age, right? If your only exposure to AI in your mind is Siri or Alexa or Google, then you're missing out on the nuances, Terry, of what you're talking about, which is the prompt engineering, like the right type of questions to ask to get clear answers. That there's an art to doing that, a way to do that, and we're not teaching that to anyone. And so you are going to get nebulous questions. You are going to get questions in which hallucinations can be brought into because it's inferential, because it's trying to make an answer with incomplete information. And so you will run the risk of going down that pathway, which then leads to other tests and other problems and maybe complications thereof. So part of this is, we have this individual responsibility. We also have a collective responsibility. We also need literacy. These are all critical things that we often talk about. And we've talked about this through our equity and health systems work on the CARE AI framework. These are some of those core principles that we haven't really figured out how to do in our health system or society as a whole yet. So much work to be done.
thank you, Jerry. And also, there are many comments being posted in the Q&A box in response to both of your comments, Terry and Jerry. And it just highlights how engaging this topic is, as well as there is so much more to unpack from the care provider's perspective, from the patient and client's perspective around the applications, as well as the implications of AI within our healthcare settings. So I'm wondering if we may go to our second to final slide with Terry, recapping some of the key points, the three things to take with us as we wrap up our first session, knowing that we still have 3 more sessions in this series where perhaps we can explore those questions and those comments further.
Thanks, Ruth. And thanks everyone for your engagement and your questions. So 3 things to take with you. I won't call them takeaways because you need to interpret them and make them your own, but there are 3 things that you can take with you. So the evidence for the benefits and drawbacks of AI is real but uneven. The right response, in my opinion, is not enthusiasm or dismissal. It's calibrated, transparent engagement. I would say engaging with tools that could be useful and reviewing them dispassionately, learning about these tools, how they could be helpful or harmful to you. Second, if AI is being used in your setting, I think you have a professional responsibility to understand it and to be visible about your own use and your own questions. I would like to take this moment to remind you that if you've attended a webinar, say recently on AI and AI is a big picture, you're doing this already. Good work. Keep up the good work. You're doing the right thing by seeking out more information from folks. 3, your patients have rights. Knowing what those rights are and being prepared to name them is part of informed practice now, in my view. So I think you've done 3 good things today, and I think you can do 3 more if you take a look at these takeaways and you consider how they might apply to you. Coming up, session 2 of the series is going to be Dr. Joel Mokhtar and facilitated by myself on June 9th from 12 to 1 p.m. Eastern Standard Time. It's Diagnostic AI in Clinical Care. June 15th, it's going to be Dr. David Wilger and Dr. Mohammed Madani, who is going to be discussing AI in care and therapeutics, June 15th, 12 to 1 p.m. Eastern Standard Time. Session 4 is going to be with Dr. Chandra Chandrasena, and it's going to be facilitated by Dr. Eric Wolterton of the University of Ottawa on June 25th from 12 until 1 p.m. It's on administrative AI, Scribes, scheduling, and referrals.
All right, thank you. Oh, yes.
No,
Was
go
someone
ahead, Ruth.
jumping in? Oh, thank you, everyone, for being here. And thank you to Eleftherios Soleas, which I am now hoping to pronounce better, and Jerry Maniate for our first session here in our 4-session series. Thank you to all the participants who have attended, for your questions and also for your openness and your candor in posting your Q&As and your comments. Thank you for bringing your lived experience into the session. It makes a difference. So I'll wrap up this time by asking everyone to fill out the post-session survey. This link will be sent to you immediately following the session. It will take 5 minutes, 8 minutes maybe, to complete, and it counts as part of your accredited learning hours for those that are gathering your accredited learning credits. And this survey also shapes what we cover in sessions 2, 3, and 4. So please share with us the questions that came up today and the topics that you want us to address. If you have any further questions, you can reach us at this email address, which is Terry's email down below, eks3@queensu.ca. We'll see you on June 9th. Thank you, everyone, and take care.